All right, good afternoon, everyone, and welcome to our webinar. Today, we are very happy to welcome Dr. Craig Gurgin and Frederick Damon joining us from Purdue University in West Lafayette, Indiana. They're going to give us a presentation on some of the work that they've been doing in 4D cardiac ultrasound in mice, doing a study comparing 4D mouse cardio to some of the traditional imaging techniques and also to MRI imaging. So the webinar is being recorded live as it's happening. All of the lines are muted for the webinar, so if you do have questions, please submit them through the question window during the presentation. We will have time at the end of the presentation to answer any questions which are submitted. We're expecting around 45 minutes for the presentation, and then certainly time allotted at the end to go through any questions and any discussion from there. So as I mentioned off the top, very happy to welcome Craig Gurgin and Frederick Damon. Craig is a assistant professor of biomedical engineering at Purdue University, has a background in biomedical engineering from WashU in St. Louis, and also graduate work in biomedical engineering at Stanford University. In his postdoctoral work, he did some work on cardiac disease and left ventricular remodeling. And Craig's been with the biomedical engineering department at Purdue since 2012. In Craig's lab is Frederick Damon, who is a combined MD PhD student at the Indiana University School of Medicine. I'm working on PhD in biomedical engineering in Craig's lab. Frederick has a background also in biomedical engineering and has done some research in neuroimaging and brain connectivity networks and is now working in the Cardiovascular Imaging Research Lab at Purdue using ultrasound and MRI technologies to look at biomechanics in healthy and diseased hearts, focusing on small animal models. And Frederick's plans going ahead after his training are pursuing a career as a physician while working on imaging technologies for clinical applications. So we're going to turn the presenter rights over to Craig and Frederick, and they'll start carrying through their presentation on some of this really interesting work that they've been doing. Over to you, gentlemen.
Thanks, Stephen. Thanks so much for the introduction. Thanks, Kathy, as well, for your help organizing this. Hello, everybody. My name is Craig Gurgin. I am indeed an assistant professor here at Purdue University in West Lafayette, Indiana. Thrilled to be joined as well by my student Frederick Damon today, who's getting a combined MD PhD. He's about midway through the program now. Freddie's a great student, and he's going to be covering most of the content of this webinar today. A little background about Freddie: he's got a big interest in imaging and imaging technology with a lot of focus on MRI. And when he joined the group, I convinced him to also now expand his repertoire to focus on ultrasound as well. So we'll be showing that a comparison of ultrasound and MR in our webinar today, specifically focused on a 4D cardiac mouse technique that has recently been developed with a visual sonics platform. So to start, here we have brief motivation and purpose. That cardiovascular disease is the leading cause of death in the United States and worldwide. Accounts for more than cancer and other types of neurological defects. Over 31% of the U.S. Population that dies is affected by cardiovascular disease. And if we break that up even further, cardiac disease is a big portion of that. Both myocardial infarction and other congestive heart failure play a huge role in that population of people that die because of cardiac death. Our approach is now to use non-invasive imaging to both diagnose and help with prognosis and eventually guide treatment as well. So with the idea that we're using mouse and animal models, the big real focus is on prognosis and trying to understand how diseases progress throughout time, rather than maybe understanding and figuring out diagnosis with the thought that we are causing these diseases and heart failure to occur in mice to begin with. So our animals are primarily the wild type T57 black 6 animals, the mice that have become predominant in the biomedical field. We're not saying that what we do in mice is the same as what happens in human disease, but a lot of the underlying mechanisms, genetics, and progression that kind of influence the pathology, whether it's myocardial infarction or hypertrophy are very similar to what happens in humans, with the idea that we're going to then directly test the efficacy of potential therapeutics or develop clinical metrics, or even to figure out new treatment strategies that can eventually help improve human care through improved diagnostics or therapeutics. So for the rest of the talk, we're going to focus on three separate sections. First, an overview of what's done for cardiac imaging with a traditional 2D approach, and then what's happening now with a four-dimensional or gated volumetric imaging approach with small animals. We'll then compare that to a cardiac MR data set that we have acquired with a 7T Brooker small animal system that we have available here at Purdue. And then finally, we'll focus on two different disease models. First, an infarction model where we've ligated the left coronary artery, and then a second model, genetic knockout, where we see pronounced left ventricular hypertrophy. So at this point is where I'll turn it over to Freddie Damon to cover the rest of the content of the slides, and then I'll come back in the end to wrap things up after we get through the rest of this.
Hello, everyone. Thank you, Professor Gorgon, for the introduction, and thank you for the organizers of this webinar to allow me to talk about some of our exciting research. So, as Professor Gorgon had mentioned, I'm going to start out the talk primarily focusing on the ultrasound imaging that we're looking at for being able to compare and contrast other popular gold standard techniques. So, for all the imaging that you'll see in this webinar, we use the VisualSonics 3100 system, the Vivo 3100 system, with the MX550D probe. Now, this probe is typically allotted for murine imaging, and specifically murine cardiac imaging with a 40 megahertz central frequency. What this allows us to do is actually have an in-plane resolution of approximately 40 micron, so very nice resolution. And on top of that, we can also achieve, depending on the different parameters that we prescribe for the probe, looking at about anywhere between 20 to 90 micron with an in-plane resolution. Moving on from that, we can see that we also have the EKV and 4D modules available to us on the 3100 system. And the 4D module is actually an extension of the EKV technology, taking advantage of the 3D linear translating motor. And we'll talk about the actual procedure that it uses to collect this volumetric information. On top of all this, the 3100 system also migrates itself from the 2100 with the touchscreen interface, which does allow for some more seamless acquisition. In addition to the 3100 system, one of the other technologies that we're implementing to be able to look at some of our more diseased models is a low-flow anesthesia system. It's an integrated digital anesthesia system. A paper that we put out in 2015 compared sort of the traditional tabletop vaporizers that a lot of small animal labs will use with this digital vaporizer, and by allowing us to prescribe the same percentage of isoflurane or anesthetic, we can achieve basically a fraction of the total anesthetic to the animal. So we can more safely image these animals for longer periods of time, especially if we're trying to image with multiple modalities at very precise time points. Now, just for the sake of the study that we're presenting, we used a 10 milliliter syringe for the isoflurane liquid, and we prescribed it about 150 to 250 mils per minute, and that really depends on whether we're using the ultrasound or the MRI system. Now, you can see here the tabletop experimental setup that we have on the left side here. You can see our SomnoSuite system, that low-flow vaporizer system, both allowing airflow to the knockdown chamber in between the stage and the SomnoSuite, as well as tubing that goes to the stage itself. And similar to the nose cone that's available with the VisualSonics system, we can have animals sit on the stage with the low flow anesthesia. Now, for the rest of the talk, as Stephen had mentioned, we're going to be talking about a lot of murine imaging, and specifically to this data that you're going to see, we're looking at both wild type and hypertrophic and myocardial infarction-induced C57 black 6 mice. And I'm really just putting this here to give everyone a scope of what we're about to be looking at. And I'll talk about more specifically the properties of each of these mice later in the talk. So when we look at conventional ultrasound techniques, sort of what has been used as the gold standard for echocardiography, when we're looking at mice, we have both the standard short axis M mode with points that you can delineate across the time course, both on the luminal border, the endocardial border, should I say, and then also the epicardial border, both apically and down towards the spine. And what this allows us to do is make estimations depending on estimated geometries of various cardiac measures. And I'll go into more detail in just a second here. But also, in extension to the one-dimensional approach, we can also have planar 2D approaches with B-mode imaging. And this allows us to assess cardiac functionality with a little bit more specificity to the actual cardiac geometry. Now, I had mentioned that a lot of geometric assumptions need to be made. In past literature, a lot of different models, geometric models for the left ventricular lumen have been put out with various efficacies, and but we're basically moving on now to approaches with in vivo imaging that allow us to extend past these estimations of left ventricular geometry. And this is really because, as you'll see later, the measurements that we see, while they are good estimations, can sometimes be inaccurate, especially if we move towards more complex models of left ventricular function. Also, because these models are explicitly using time points both at end diastole and peak systole, we are a little bit limited in how much dynamic information we can acquire. However, we really do use these geometric models not only with our murine imaging, but these are used clinically to give sort of parameters of cardiac function or cardiac measurements. This comes down to ejection fraction, stroke volume, cardiac output, fractional shortening, and left ventricular mass. A lot of common measures that you'll see that describe any person and or subject's cardiac function. Now, sort of going back to these conventional approaches, we can see the B-mode imaging, which is a two-dimensional planar ultrasound approach on the left video, allows us to acquire, in that specific example, about 78 frames per second. Now, a couple of factors that can go into allowing us to up that frame rate can be the actual acquisition width, or how many elements we're looking at the image with. We can change the number of focal zones or spacing of the focal zones to try and increase the speed, as well as we can shift the number of samples down the image we are trying to acquire. But regardless of any of these different approaches, this is unmatched by the technology that the ECG-gated kilohertz visualization module can give us. Now, this allows us to gate both by ECG and respiration signals from the animal to acquire this very nice 2D planar information. Now, what we do for our 4D approach is take this EKV image at any given point, and you can see here with the bottom left, we basically are able to equally space out the snapshots of the plane across the cardiac cycle. Now, taking advantage of our 3D motor, if we actually acquire these EKV loops all across the cardiac field of view, we can then extract both ECG and respiration information to create a volumetric snapshot of the left ventricle at any given point during the cardiac cycle. Then compiling all of these volumes, we can acquire our 4D ultrasound data set. All of this being done in very rapid automated sequencing. Now here you can see an example of our four-dimensional data set. On the bottom left, or sorry, on the bottom right, you can see a link to the 4D imaging technology that's available with the 3100 system. Now, what we have here is some advantages and disadvantages that we really do need to recognize, especially when comparing to other imaging modalities. With the advantage of spatial and temporal resolution, we really need to recognize that this is still inherently an ultrasound technique. So we need to consider gas and bone artifacts that can be present when imaging cardiac tissue. Also, the field of view is very dependent on the probe that we're using. So while the 550 is fantastic for looking at cardiac tissue in the mouse, when we're moving to different animal models, we really do need to make considerations as to the types of probes that we're using. Also, along with the field of view in plane, the depth of the image is dependent on the frequency of the probe that we're using. So there's some hardware considerations that we need to make. But with all these disadvantages, I do want to wrap back around to the advantage of this very high spatial and temporal resolution. As I mentioned, about 20 to, let's say, 90 micron in plane, as well as a 40 micron through plane resolution. And all of this can be acquired in the matter of 5 to 10 minutes on the 3100 system. It does, we can also acquire this with the VIPO 2100 system. That's where some of this original work had come from. It does require some offline processing and a little bit longer acquisition, but regardless, we still have the advantage of very rapid acquisition. Now, as an extension, we can now use this 4D data to mask both volumetric information of the luminal LV or mask out the actual epicardial wall. And taking all of this into account with the temporal-based information, we can actually have that dynamic information that we are sort of limited to when using the conventional ultrasound approaches. And you can see here the image that you see on the right where we're done with a little bit of more post-processing, and you can see that they're also taking into account the papillary muscles, which you can kind of indicate with the divots, but essentially all this information can be extracted from our 4D ultrasound data without any sort of geometrical assumptions. Now, that is sort of laying out a lot of the ultrasound technologies that we're implementing. The MR technology that we're going to be looking at, we're going to be considering somewhat of a gold standard approach, something to compare against to see how accurate we're acquiring, or how accurate we're measuring these cardiac functional measurements. Now, I understand that while this crowd may be a little bit more ultrasound inclined, I will try and lay out some of the MR technology that we used and give it in a sense that should be easily digestible. So we're using a 7 Tesla Bruker small animal magnet. This allows us to have very nice signal from our smaller mouse samples. And we're using something called a fast low angle shot or flash sequence. And to break down a lot of these more specific parameters that you're seeing, the TE and TR stand for the time of excitation, or sorry, time of echo and time of repetition. And really the takeaway here is about every 7 milliseconds, we're acquiring another sample of data from our fields of view. Now you can compare this when we're using the EKV, or at 1,000 frames per second, we're sampling the data at approximately 1 millisecond. And with the increased frames per second, we could even go sub-millisecond. So you can see here that this is, the 7 milliseconds is about the hardware limitation that we have available to us, and that temporal resolution can be even faster with ultrasound. In that same regards, we can see that our movie frames that we're acquiring with our MR data is about 14, and you can compare that to about 20 to 30 frames for the 4D ultrasound, and that's because we're using it about 200 to 300 frames per second to acquire more rapid, or to allow for more rapid acquisition, but this can go 100 plus frames if we want to up the frames per second of our ultrasound acquisition. Now, field of view is something that's comparable to our ultrasound system. For MR, we're looking at about a 30 by 30 in-plane field of view. And if we're using a standard 256 by 256 matrix size, so that's basically you're taking your 30 by 30 field of view and slicing it into 256 by 256. We're dealing with approximately 100 micron in-plane resolution, so not quite matching that's available to us with the ultrasound. But and another limitation, which I'll touch upon again in just a second, is in order to acquire enough signal from our MR data, we do need a thicker slice. So while we have about 40 micron through plane resolution with the ultrasound system, we have about 1 millimeter slabs or slices that we're acquiring. And with these 1 millimeter thick slices, we are acquiring about 8 to 12 adjacent slices to cover the whole left ventricle, whereas with the ultrasound we can go maybe 50, 60 plus slices. So that spatial resolution is a little bit more limited. Now, on top of all this, we do have the Bruker Intragate in-slice navigator. It's basically a commercially available technique that allows us to gate by respiratory and cardiac signal straight from the MR signal, so we don't necessarily need to gate by the ECG and respiration information. However, we do use the SA Instruments monitoring system, which is quite standard for a lot of small animal MR systems that allow us to monitor the physiological properties of the mouse while they're in the scanner. And this is done through subcutaneous ECG leads, a respiratory-based pillow sensor, or sorry, pressure-based pillow sensor for respiration, as well as a rectal temperature probe. And this is attached to a warming fan that is on a feedback loop that keeps our mouse at a constant 37 degrees body temperature. Now, sort of putting together everything that I was just mentioning with the MRI system, you can see on the bottom right of this loop is a long axis, or what is considered a 4-chamber view, being sliced up by the 10 slices of, or the 10 slices that would be acquired with the MR system. And while we get a very nice in-plane image that you can see is the bottom left, our through-plane resolution is a little bit limited. However, this is still considered somewhat of a gold standard in the field of cardiac function measurements. Now, to sort of reiterate some of these advantages and disadvantages, starting with the disadvantages, as I've alluded to multiple times now, we do have a limitation with our through-plane resolution. If we wanted to push the slices thinner, we do sort of lack the proper signal to delineate the luminal wall border. Also, the signal-to-noise ratio, or basically the quality of the image, is proportional to the scan time. So we could acquire very nice images, but this would be, sticking the mouse in the scanner for hours or more at a time. Also, you can see in the center of the lumen this sort of flashing black to white. That is a flow-based artifact, and without getting too far into the actual MR physics, essentially you have blood entering from out of slice area. So as the blood is pumped from the atria into the ventricle, it causes this sort of washing effect. And this can sometimes be a hindrance to the luminal border delineation. However, using the right parameters, we can get around a lot of these effects. And I've talked about this before, but the temporal resolution, it's essentially 14 movie frames. So assuming 120 milliseconds from R to R cycle, we're about a 10 to 15 milliseconds temporal resolution from frame to frame, compared to something close to 1 to 5 milliseconds with the 4D ultrasound. However, with the MR technology, we do see that we can look at left and right ventricle wall borders, whereas some of this can be hard to see in the ultrasound due to bone and gas artifacts. And we also have a very flexible field of view. Basically, however we want to prescribe our imaging plane, we can do that, as well as, depending on the actual MR parameters that we want to use, we have access to somewhat of a flexible contrast. We can make the soft tissue darker or brighter, and we can have some similar considerations when looking at the vasculature. Now, as I had mentioned before, I wanted to reiterate our imaging subjects, and really it's because for the slides you're about to see in our comparison between the ultrasound approach and the MR approach, we're specifically focused on our 5 wild type and 5 hypertrophy mice. And if you consider all of these to be subjects in the same pool, we can compare our 3 different methods as we have laid out before, and look at some of the cardiac measurements that are standard to looking at cardiac functionality. So you can see here moving from the top from left to right, we have end diastolic and peak systolic volume in microliter units, and on the top right we have stroke volume, which is essentially the difference between those two, also denoted in microliters. In the bottom left, we look at ejection fraction, a very common cardiac measurement, which is the stroke volume divided by the end diastolic volume, and we make that a percentage by multiplying by 100. And then also in the bottom right, we have left ventricular mass. So that's taken during end diastole, basically subtracting the volume, the total volume as denoted by the epicardial border by the endocardial border. And that is multiplied by 1.053, which is a correction factor to essentially move from volume to mass. Now, if we take all 3 of our imaging approaches and apply a one-way ANOVA to look at the agreement between these measurements with a 2-key post-hoc multiple comparison, we can denote that essentially our 4D and MRI techniques have the closest agreement. These are essentially outside of peak systolic volume has been shown to be closest to essentially no difference. Now, the difference between group means, these are all in absolute value, so the units that you would denote for each of these different measurements are extrapolated here. Now you can see that there are some comparisons that show statistical significance using an alpha value of 0.05. And the main takeaway here is that those significant differences tend to occur when we're looking at the short axis M mode. So the one-dimensional or two-dimensional plus time approach does seem to have some disagreement with the gold standard measurements. And we also have done a 2-way ANOVA, also taking into account our wild type versus hypertrophied mice. And still this trend holds up where we see no significant difference between the measurements made by the MRI technology as well as the 4D ultrasound technology. Now, if we extend this to look at these modified Bland-Ullmann plots with the measurements in the same location on the screen as the prior slide, if we look at the difference between 4D ultrasound denoted in blue and short axis MO denoted in red, not only do you see a closer agreement for all the individual data points with the 4D ultrasound and MRI, but you can see a wider plot, a wider distribution with the short axis M mode. So overall, we're seeing that if we're going to extend looking at cardiac function with ultrasound, using the 4D ultrasound approach is going to be the closest to acquiring true values. Now, I've sort of laid out at this point both the ultrasound and MR technology that we've applied for our study, but now we want to see where we can take this in really looking at different disease models. And giving both an example of ultrasound as well as MRI, we can see that we've got one model, it's a genetically induced model of hypertrophy, as well as a surgically induced myocardial infarction model. And just as a reminder, all of these mice are C57 Black 6. So taking a specific look at our genetic model of hypertrophy, this is a model that's been developed at Purdue University with details to be published soon. So without going into too much detail, you can see that not only is there an increase in size of the left ventricle myocardium when we look at the diseased mice, there's also somewhat of a dilation of the left ventricle when we extend to late stage. And this is just what we can see with histology. Now extending to looking at our 4D ultrasound technique, allowing us to rapidly acquire this information for monitoring of disease progression. You can see for our wild types, we get a nice sort of ejection of the left ventricular lumen, whereas when we look at the early stage disease, while it does seem as though the left ventricle is pumping appropriately, that the left ventricular myocardium appears somewhat thickened. And even further, if we move into the late stage disease, not only is the wall thickened, but there is a compromise in the ability for the left ventricle to pump. Moving back into looking at our three different techniques, just to sort of reiterate the trends that we were seeing in the comparison of these different these different techniques. In red and green, you can really focus on the fact that there is a very tight agreement in the values that are being observed, both when we look at the wild type mice denoted on the left columns and the diseased mice, as you can see in the right columns. Now, when you look at the blue, we do notice in just about all of these different measurements, there is a wider spread, which indicates potentially a disagreement with the, or should I say an inaccuracy to the actual true values that we would be expecting. And just for note, if you're looking at the diseased columns, the right blue, red, and green bars on the right side of each of these different plots, the spread of the data is really indicative of the different stages of the disease. So this, while we're just looking at the pure measurements, we can see that we can start to characterize the actual stage of the disease. Now, to really look at our ability to delineate these different diseases, all of this information shown here was done with our 4D ultrasound technology. Comparing ejection fraction to stroke volume, we can see that, you know, our wild types in our early stage disease are all kind of providing a comparable ejection fraction, whereas the late stage disease does seem to fall off a little bit. And a comparable effect is seen when we look at stroke volume versus end diastolic volume. That late-stage disease is showing that dilation as we had expected when looking at histology. However, when we then add in the actual left ventricular mass measurements, we can start to identify actual clusters of our data and characterize, or should I say, estimate the actual properties of these diseases using the 4D ultrasound technique. Now, all of these measurements are also acquired with the MRI approach. However, as I've alluded to before, all these advantages and disadvantages that we have between these two different techniques, being able to have access to rapid acquisition of volumetric information allows us to do these kinds of studies very quickly and with high reliability. Moving into a surgical model of myocardial infarction, I'm just going to sort of lay out the procedures that we go through. On the top left, you can see we intubate the mice using a fiber optic light source that is fed through a catheter, and by monitoring the animal and anesthetizing them using isoflurane with that low flow anesthesia system, we can ventilate the mouse. And then once they're ventilated and properly anesthetized, we perform a left thoracotomy to expose the epicardial border, epicardial wall. We then identify the left coronary artery, and using a suture, we can tie off that artery and induce a distal infarction. And then once the tissue is, once the artery is ligated, we can then suture the animal back up and allow for recovery. Now, this is a model of myocardial infarction that has been widely used, and we are getting it up and running in our lab for further studies. And as you can see here, this is post-mortem dissections alluding to the actual infarcts that we can cause. You can see both a small infarct on the left as well as a large induced infarct on the right. Now, if we sort of use our in vivo imaging to characterize this small and large infarct, commonly we would see with MR this wall thinning as well as a dilation. And those effects can also be reproduced and seen within our ultrasound imaging. And I just want to note with the large infarct, this extension of that wall thinning and dilation. Now, specifically looking at our small apical infarct, you can see both the ultrasound and MR data in cine loops in the bottom right, as well as a 3D rendering of our volumes on the left. And measurements that we've made for end diastolic volume, peak systolic volume, stroke volume, and ejection fraction, comparing the three different techniques. So 2D ultrasound, 4D, and MRI. And then if we actually compare the values that we're achieving, we can see the same trend with very nice agreement between our 4D ultrasound imaging as well as the conventional, or should I say gold standard MRI approach. If we extend this to our large apical infarct with the same layout on the slide and the same measurements being performed, once again, we can see that there is a very nice agreement between the 4D ultrasound technique and MR, whereas that agreement tends to be a little bit larger when comparing the 2D to 4D ultrasound. Now, at this point, I'm going to hand the phone back over to Professor Gorgon, and I'd like to thank you all for your time and attention.
Great, thanks, Freddie. So I'll just wrap up with a few takeaway messages with specifically this 4D ultrasound approach. We're using a gated volumetric analysis to compare cardiac function with both standard 2D ultrasound as well as volumetric cardiac MRI. If we consider MRI a gold standard, the 4D compares well and even better than the 2D approach, especially for complicated disease models where hypertrophy or infarction leads to complex geometries. And really with this 4D technique, it's very high spatial and temporal resolution with fast scan times that allow us to get volumetric information with this ultrasound approach that currently was only available with more complicated large small animal MR systems. We applied this to two different cardiac disease models, both a genetically induced hypertrophy model and then also a standard infarction model where we tied off the coronary artery. Again, both of these are great standard models to show the applications of this 4D approach for a wide variety of assessment for cardiac function. I think we could even apply it to a great deal more different disease models, not only in the heart, but in vascular motion and dynamics as well, beyond just cardiac. So with that, I'd like to thank Freddie specifically, but also the rest of the Purdue Cardiovascular Imaging Research Laboratory, as well as our collaborators at Fujifilm Visual Sonics in Toronto. Christina has been a fantastic help for some of this 4D work, and Stephen's been wonderful to work with as well. Both of them were able to come out and see our setup and work with us on some of these projects a couple months ago. And then the rest of the Visual Sonics team. Our funding sources for the lab from the American Heart Association, NIH, NSF, and several foundations, including the Indiana CTSI and a few others. I'd like to again thank Freddie. He did a great job putting these slides together and getting all this data ready for presentation, as well as say that both of us are happy to connect to anybody interested in learning more about our technique or interested in collaboration as well. And then finally, I'd like to point everybody to our website and both recently established Twitter and Facebook feeds for more information about what the Purdue CVIRL is doing. And with that, I'd like to thank everybody for their attention.
Great. Thank you, Craig and Freddie. It's a great presentation. Really, really awesome work you guys are doing. I really liked some of the data analysis you did, showing how much more reliable some of the functional calculations are using the MR and the 4D data. We do have a couple of questions that have come in here. One question is, do you have any experience with either platform, 2100 or 3100, in developmental cardiovascular imaging, specifically in utero cardiovascular imaging? And if yes, how do you think the calculations and measurements are? Do they have any limitations, or are the assumptions problematic, or are they okay?
Sure. So I'll preface this with, we're not primarily focused on embryology or development work, but we do have several close collaborators that are looking at, anywhere from early stage P7.5 all the way up to birth at P21, and development of many internal functions, including the cardiac system and aorta. So I would say, I think it really depends on what stage you are in development when you're assessing cardiac function. Obviously, the later stages, when the heart is more developed, it's already gone through that looping process and the 4 chambers are there, it's a little bit easier to then correlate to the standard adult approaches. But I do think a volumetric analysis, and I'm not sure it's going to work for every single embryo depending on orientation or where it's located, but we've definitely done in utero imaging where we can clearly see the ventricle beating inside these embryo along the uterine horn, where we can get a better sense of mostly flow, looking at flow through the aortic valve even at these early time points, but we haven't done a lot of volumetric analysis yet. So that's something that would be certainly interesting for future work.
Yeah, I agree. I would sort of throw in my own experience, having done lots of imaging on our system too. I mean, the heart is very, very easy to image and view in utero, and Doppler works well for looking at blood flow. There is a bit of a question about whether or not the calculations that are based on the adult model are applicable. They do work. You certainly can do wall thickness measurements. You can do tracking. You can even do strain and speckle analysis tracking on the embryonic heart. But the question of whether or not the math in the background there is entirely applicable to the embryonic heart is always a bit up in the air.
Yeah, I'll just add that. Right, so then this 3D gated approach or 4D approach makes a lot of sense then if you can do a very small step size to get direct measurements without then having to assume any kind of geometry with a 2D approach. That would be a great application.
I agree. We have two questions here actually on, which is interesting. Obviously, there's lots of interest about this particular topic out in the field about 4D imaging, either with MR or ultrasound on the right ventricle and right ventricular function. Any comments there?
Yeah, so that's something we've thought about as well, and there are now several disease models. It's certainly, let's say, underexplored compared to the left side, but right ventricular dysfunction is a big problem as well. And so I'd say that the biggest practical limitation for us is the issue of the sternum, and trying to get great signal and boundary delineation of the right side with our typical LV imaging approach is often difficult because the sternum lays right on top of that. But I think if we modified our orientation angle, the transducer angle, to better view the right side, I do think that's possible. And we've got several good data sets where even though there is a rib cage and sternum shadow across it, we can see the right ventricle beating similar to those four-chamber MR views that I think will allow us to look at right ventricular ejection fraction, stroke volume, and general function. I'll let Freddie chime in as well with a few thoughts from his end.
Yeah, so in regards to the MR imaging, that is definitely something that is commonly used in order to look at right ventricular function. You do get a lot less of the flow artifacts because of the slower velocities going into and out of the right ventricle. So using MR, it can be done quite easily, very similar to how any sort of measurements are made for the left ventricle. And I'll just reiterate what Professor Gorgon had mentioned, in that it really just comes down to orientation of the probe with our ultrasound imaging to allow us to look at that right ventricle. So in no way do I think it's impossible with the right considerations. Looking at right ventricular dysfunction can be done with either technique.
Yeah. Thanks both. Again, that's been my experience as well, imaging with the system. I've definitely had more luck with Doppler methodologies too, looking at flows through the tricuspid and flows out of the across the pulmonary. Any comment on that? You know, sort of whole ventricular wall thickness measuring versus more functional measuring using Doppler?
So we have done some measurements with Doppler looking at ENA wave velocities through the mitral valve. So with some interest in diastolic dysfunction, we can actually use the ultrasound system to look at the probe, or to look at the actual blood flow functionality. Now that is somewhat reproducible with the MR imaging with phase contrast techniques. Without getting into too much detail, as I said, some of those measurements can be made with MR, but really, as Stephen has mentioned, they are very more robustly acquired with the ultrasound.
And I'll just add, from a transducer orientation standpoint, right, the ENA wave worked well for us when we're coming in from the apex of the heart, coming up towards the base to see the mitral inflow coming towards the transducer. But the right-sided imaging seemed to be best, tilting the animal even further and coming in at a higher angle from the left side, trying to get across the sternum underneath. Whereas if we come in on the right side of the sternum, the animal's right side, the lung artifact there really limited the view. Stephen, would you agree with that it's harder to come in from the right side?
It is, yeah, absolutely. That's been my experience as well.
Yeah. Okay.
All right. Another good question here about inter and intra operator variability in the imaging and whether or not versus this technique, the 4D ultrasound technique versus more conventional ultrasound measurement techniques.
Yeah, so that's something certainly to consider. We want to be cognizant of what's, you know, a change due to actual biology versus just the fact that the operator acquired slightly differently or analyzed the segments, the left ventricle boundary slightly differently on a specific animal. So what I would say is we're working with our 4D approach and coming in thinking that that actually will help reduce that interoperator variability, because now instead of really being specific to an angle that the transducer is requiring, that one slice, you can basically find the middle of the ventricle, try to get a nice view between the sternum and the lungs, and then hit the button and acquire that full volume. And then from the acquisition standpoint, we're also working on ways to do some automatic segmentation where instead of manually drawing and trying to decide where exactly that boundary is, we can place a seed in the middle, expand that out, and then poof, you've got a nice clear LV boundary that may or may not require a little bit of manual correction, but hopefully that will reduce any kind of variability between operators as well. And with that, we're thinking that it's going to be a helpful way to reduce that spread, especially with groups that don't have access to people that have been doing this for 20 years and have a great deal of experience with cardiac ultrasound in mice.
Mm-hmm. Yeah. Mm-hmm. Yeah, certainly the experience, just learning and learning where to place the points and learning how to place the volumes right. is the key. There's actually a follow-up question about that, just about whether or not you find any challenges, especially sort of at the outer, I guess what you could term as the outer edges of the image, where you're getting close to the walls and then past the edge of the wall. Any issues or concerns with tracing the boundaries, and any sort of, I guess, tips and tricks for working around that for getting good placement of the boundaries to get good volumes?
Yeah, I'll let Freddie comment on that, but I'll just say at the beginning, it's really hard in these infarction models where you get a thin wall and there's often a lot of attachment between the epicardial boundary and the wall itself. That opening leads to scar tissue formation that really brings that together, making it a firm attachment between the cardiac tissue and the border around the outside. We played with contrast and trying to get a consistent contrast, and even overgaining some of the samples to get a better delineation of the endocardial boundary, and then reducing the gain to get a better delineation of the epicardial boundary. Fred, do you have more thoughts on that as well?
So I think this is actually where the volumetric imaging really has its strengths, being able to sort of mask these images firsthand. When you're looking at a single plane, you do have to make some assumptions as to, okay, where are things being connected, especially if you get some shadowing artifacts. But when you have the 3D information and you can look at the image through multiple planes, it allows you to, at least in your own head, be able to piece together the information. You know, wherever there might be, gaps in being able to find that luminal border. If you can see it in 3 different planes, well, then it just allows you to assume, okay, I'm looking for this, cone-shaped wall. Where can I draw my border such that it's consistent across all these different planes? And so that's one of the advantages that we really have when we're looking at the conventional sort of 2D M mode or B mode approaches versus the 4D. You can really slice it however you want to get a good understanding of where all these borders should go. And I will say that once you have access to that volumetric information, it's significantly easier to know exactly where to place all of these boundaries. Whereas sometimes I know when you're placing your M mode probe down the center of the left ventricle, you kind of have to make some assumptions as to, okay, at the bottom of the heart where it starts to have that bright sort of artifact, well, you can tell in the 4D where exactly that border should come down. So it does make it a little bit easier to mask in that regards.
Okay, great. Those great tips all around, yeah. A couple of questions, maybe just the final set of questions are both related. Could you comment on the time involved in the different modalities, both the acquisition time and also the data analysis and data reconstruction time? How do the two modalities compare and contrast with one another?
So I'll start off with the MRI, just because, as we'd said throughout the presentation, it's kind of our standard. approach, each slice that we acquire will take approximately 5 minutes. There's some variability there, you know, somewhere between 3 and 8 depending on all the different parameters that we set up, but to acquire a single slice with good signal, it's approximately 5 minutes. So you're looking at about an hour's worth of scanning to acquire the full volume of the left ventricle. In regards to the 2D or conventional approaches, I mean, that's basically on the order of 5 to 10 seconds, depending on what technique you're using. And then when you extend that to the 3100-based 4D imaging, if we're using a frame rate of about I think it was like 300 frames per second, that's used for the 4D imaging. A full volume with good resolution takes maybe 6-7 minutes. So essentially a fraction of the time that would be needed with the MRI. So as I'd say, the spatial temporal resolution that we can achieve with that rapid acquisition really is that strong suit of the volumetric imaging.
And I'll just add on top of that, with ultrasound, it's really a trade-off between the amount of data you're going to acquire and how long you want to take to get it. So if you need really high temporal resolution and great slices that are with small step sizes, you might take a little longer, but if you can are concerned about the animal or can get away with bigger step sizes, you can do much quicker acquisitions just with quick modifications to the 4D acquisition.
Mm-hmm. And what about analysis and sort of data management at the end of the two modalities, and like in terms of placing volumes and analyzing the images? How do they compare and contrast?
So in regards to the analysis, I mean, depending on how exact you want to make all of your maskings, I would say each data set for me took about, and I'll preface this by saying the amount of time that it takes to analyze the 4D ultrasound versus the amount of time it takes to analyze the MR is pretty much the same. I mean, you're dealing with volumetric information that you're trying to mask, and interpolations depending on where you place a lot of your sort of seed points of where, you know, that luminal border is. A lot of that stuff can be extrapolated. So if we're just assuming we're looking at manually masking out end diastole and peak systole, maybe a half an hour to an hour's worth of analysis per modality per animal. So I mean, for a larger study, if you wanted to make more rapid analysis, you know, you could do it on the order of 10 to 15 minutes per animal. But I was just, for this specific study, it took about a half an hour to an hour per modality per animal, just to make sure that I was really getting the exact geometries.
Mm-hmm. And then I'll just add too that we kind of take the approach of it's best to acquire as much data as we can, having, you know, some thought about how the animal's doing, and then later on, if we only want to segment every third slice or every fourth slice instead of every single one, and we can prove that it's giving us the same results, then that's probably the better approach versus doing a quick scan and not having data available to go back and get more detailed volumes if we realize we need those later.
Yeah, that's definitely a good consideration. I mean, if you've got the animal there, you've done all the prep work, just get a really solid scan, and then, yeah, as you alluded to, you can slice and dice the data to whatever level you feel that you need later on post-acquisition with all the tools that are available today.
Yep, exactly.
Okay. Great. Okay. Well, it's just getting to 2 o'clock now, so I think it's about time we wrapped up. So I do want to say thank you very much again to both of you gentlemen for presenting. It's an excellent presentation and some great work that you're doing there. So we're looking forward to the next steps in the studies. So just to comment with regards to our products and our presence, certainly please visit our website. We have a newly updated website and customer resource portal with lots of information on it about products, about options that are available, information in terms of how to use, how to require images, data analysis, there are certainly options there too for requesting support if you've got some specific questions. We do hold regular webinars, so please check back and see what's coming up next in our webinars. And we also do lots of conferences as well, so small, medium, and large trade shows globally. So we do maintain a list of conferences that we're going to be attending on the customer website. So please check those out. And if you do see us at a conference, please stop by, say hi, and go ahead and pepper us with any questions or concerns that you might have about the technology and the system. We'll do our best to try and help you out. And thanks again very much to Craig and Freddie, and we'll call it a day. Thank you very much for attending, and a recording of this webinar will be made available by email and also on our website shortly after. Thank you.